Hello, everyone, and welcome back. I'm Joe Chappelle, and you are listening to episode 20 of the OBGYN podcast. Today, I am lucky enough to have Dr. Sarah Kim with me for a brand new episode format. This is called the Monthly Checkup, where myself and a guest or two will talk about some recent topics in OBGYN or medicine at large. I hope you enjoy the discussion on recent events, and so with that, why don't we get started? Dr. Kim, are you ready?
I'm ready.
All right, so let's do it. The first topic today is actually a CDC article or bulletin that was published last month, and I'll summarize it first. Essentially, it describes the case of a woman who delivered at 37 weeks, who was found to be GBS negative. The baby unfortunately developed GBS sepsis right after birth, was admitted to the NICU, and was treated for 11 days with ampicillin. That particular strain of GBS, and this is important, was penicillin sensitive, but clindamycin intermediate. So after the 11 days, the baby was discharged home, and then 5 days later was readmitted with late onset GBS sepsis. Now, this is, like I said, was important. This particular strain the baby had now was penicillin sensitive and also clindamycin sensitive, and so we assume that it's a different GBS strain than the first one it had. Now, where the case gets interesting and where the CDC comes in is that this mother had started eating encapsulated placenta 3 days postpartum. When the admitting doctor found out about this, she asked her to stop eating the placental capsules, and she had the placental capsules tested. They found that both the capsule and the infant both tested positive for the saved strain of GBS. And so presumably the infant had late onset GBS sepsis due to maternal colonization from eating encapsulated placenta. And so I thought this was a very interesting topic about something that has become, I think, more prevalent, or at least more people talking about it in the last few years. But there's really little science behind it or data behind it. And it brought up at least, maybe rare, but definitely a complication of that.
Yeah, I agree. Just reading the article, it made me realize, especially being on the floor, I feel like I'm seeing more and more patients requesting to take the placenta home for encapsulation. And I think most of them use different companies. And to be honest, I didn't really know what their process is. And after reading this article, I kind of looked at what different companies do to kind of go through the process of encapsulation, and there's really no standard protocol. And that's what's kind of concerning. And I wonder if people, when they request to take the placenta home, how much research actually goes into what company A is doing versus what's company B. And the fact that none of this is regulated is also kind of concerning, because that could definitely lead to, more of these uninformed decisions that potentially will lead to an event like this.
That's exactly what was my thought on it as well. I think this is going to end up being a podcast episode of its own about placental encapsulation, because it's interesting. Mm-hmm. But when I look at it, I start thinking, okay, so what are the beneficial effects, and then what are the risks, right? Like we do with any treatment or anything else, right?
Right.
And so for this, I did exactly what you did, and I saw, what are people doing? Mm-hmm. And there are some companies, but there's also just a lot of people online who do it themselves.
Right.
And so what I found, the process for those at home who don't know this, like I didn't. Mm-hmm. So what most women do, or most companies do, is they start by steaming the placenta for 15 to 30 minutes to cook it. Mm-hmm. Right. And then after it's been cooked, it usually loses about half its volume. They then cut it up into strips and then bake it in order to dehydrate it. And that I found very variable numbers. People did it for 6 hours, 14 hours, 24 hours, and the temperatures were all over the place.
Right. Yeah, I found the same thing where they say the protocol was they steam it, and they think that's the way to kill the bacteria, and they call it the baking process desiccation, but there's nothing that shows one method that's better than the other. And kind of the article says, like, heating at 130 degrees Fahrenheit for 121 minutes is required to reduce salmonella bacteria counts by 7 logs. And I wonder if the protocols that these companies have made have looked into, what is required to kill X amount of colony counts of bacteria, because they are all over the place.
Yeah, agreed. And I would love to see some research where, hey, maybe we could do this, where we take some placentas and you culture them before you do anything, and then you steam them for certain temperature for a certain number of minutes, and then you look at the colony counts again, and to see how long do you have to do it before you get rid of most of the bacteria.
I agree. That would be an excellent way, I think, to kind of see what would be maybe the standard protocol. And I wonder if these companies even did something like that to kind of test to what would be the way to best to kind of kill the bacteria. At least from what the companies, I didn't really see too many references or trials or studies that kind of looked at that.
Yeah, I mean, at least at our hospital where we both work, I know that there aren't really companies that are doing this. There are people, right? And you call this woman who comes and picks up your placenta, and then a couple of days later, brings you the capsules to eat, right? Now,
and sometimes we even joke around, like, how do you know it's even your own placenta? Because there's no way to know that.
That's entirely true, and we could bring that all the way back to how do you know what you buy at the health store is what it says it is, right? Because it's not regulated. And then if you look on these websites, these women say, I'm saying women because it's mostly the women who post these blog pages, but they say, well, don't cook it too long because then you're reducing the nutritional benefit of eating the placenta, right? Like cooking vegetables, right? Don't cook your vegetables because you're getting rid of the nutrients, right? But right there, we're running against this, up against the bacteria versus nutrients. And again, we don't know how true that actually is because no one's actually looked at it.
Right. Right. And even looking at the pros, I agree. Usually the biggest argument for placenta encapsulation and to ingest it is for nutrition. But how much nutritional content has really, did we test the capsules to see how much nutritional content it actually has? And I'm not sure they really looked at that.
Yeah. So I could only find 2 studies, and they were from the same group. And one of them, this is by Young et al. In Nutritional Research, published August 2016, and they took encapsulated placenta and they tested them to see how many elements were actually in there. So they found that if you took, I forget exactly how many capsules per day, but whatever the capsules, I guess 3 times a day, you got 24% of your daily iron intake for a breastfeeding woman, 7.1% of your selenium, I don't know how important that is, 1.5% of your zinc, and 1.4% of your copper. They also found that there were trace amounts of arsenic, cadmium, lead, mercury, and uranium. So, again, and they were really trace and well below what the FDA considers to be, safe. So it's okay. But that got me thinking, all right, well, so you're getting at least iron and selenium. So that's something, right? So how important is that? Well, this same group then went back and looked at women. They did a randomized controlled trial, double-blinded, with encapsulated placenta versus placebo. And they found that although, yes, the encapsulated placenta had more iron, the women had no difference in any of their hemoglobin or hematocrit indices or their iron levels after a month of eating their placenta.
Oh, that's actually pretty impressive. That's a good study to look at. And I wonder if women know about that when they're, going and signing up for this placenta encapsulation. Because if one of the biggest reasons, and we talked about the risk and benefits, if one of the benefits that we're talking about is nutritional value, and it's not really adding to the value, nutritional value for the women, I wonder if it's even worth taking the risk of possibly neonatal GBS sepsis.
Right. And I think, we talk about this a lot, and we're going to talk about it in one of the other topics today, but you get into number needed to treat, right? If your number needed to treat for benefit is, say, 50, and your number needed to treat for a bad outcome is 100,000, well, sure. But that's probably, unless the risk is really bad, that's probably a good trade-off. However, no matter what your risk is, even if it is 1 in a million, let's say that this only happens, once a year in the United States, but there's no benefit, well, then we shouldn't do it.
Right.
Right. I know, and there are going to be people who listen to this who are going to say, well, there are probably other benefits other than just nutritional. Maybe it's hormonal. There are people who say you can eat the placenta for oxytocin, for uterine contraction, and things that maybe we don't understand yet. And I'm willing to accept that we don't know everything, because I don't know everything.
Right.
And I don't know how common this particular risk is. And I'm not saying we should change anything necessarily, but I think it's a great time to step back and say, women are doing this more. Let's start devoting some research to it and find out if it's good and give women the data they need to make an informed decision.
Right. And I wonder how much of this is up to us as OBGYNs to counsel or talk about the risks with the patients. When patients ask to take their placenta home, I'll be honest, I don't usually go in the room to tell them, here are the risks of placenta encapsulation, and there's no really study that shows the benefits. I just say, okay, and I let them take it home. But I wonder if it's something that maybe we need to think about. Do we need to have a discussion with the patients and kind of at least let them know so they could make a more informed decision? Although I agree, we don't have big data to kind of give them the best kind of counseling at this point, but maybe that's something that we need to think about as well.
Yeah, I think for right now, all we can really do is ask, I like to ask the patient, why are you doing it? What do you feel like you're getting out of it? Because they may say, well, I heard it's good for my iron levels. Well, at least I can say with that, doesn't seem to be. But if they have a different goal, and I have no data to go for or against it, I think what you're saying is the least we can do is say, well, there's not really good data here, and there is some data that maybe there's a risk. So think it through and ask the woman or person who's going to be encapsulating for you what their process is.
Right, so that at least they're thinking about it. Yeah, and I agree. Instead of just saying, okay, you could take it home, I think maybe we need to make it a habit to just at least ask the patient to say what their motivation is. I agree.
All right. Well, I think there's not much we can say about that because there isn't a whole lot of data, but I think we've raised the topic, and I hope that we come back to this one in maybe a future, episode, podcast, or maybe even another discussion down the road as we get more information.
Right. I think it'll be good to just have awareness at least of, the issues, because not everybody knows about even placenta encapsulation and even the risks of it possibly. So, agreed.
Exactly. All right. So, where do we move on? This topic was actually brought to us by Dr. Kim. So, I'm going to let her give us a brief synopsis of how she came across it and what it says.
Okay. So, the paper that I decided to talk about that I thought was interesting is basically a study that was actually done in Canada. And made me think about what are some of the things that we do that we don't really think. So some guidelines that we adopt that may have other indirect consequences. So as many of you know, in 2012, the ASCCP, which is basically the American Society for Colposcopy and Cervical Pathology, changed its guidelines that lengthened the time interval between pap smears. So women aged 21 to 29, cytology is basically done every 3 years, or that's the recommendation. And women aged 30 to 64, cytology with HPV testing, which is known as co-testing, is done every 5 years, and that's the preferred method, although you could do cytology every 3 years. That's a change from before when we used to do pap smears basically on a yearly basis. And from my personal experience, I've heard many women say that they don't need to go to the annual exam since pap smears are not done annually anyway, and some simply get lost to follow-up and they forget when their last pap smear was, or even to remember to go to the OBGYNs because they would come and not get their pap smears and they would just say, I don't need to go for annuals anymore. I think the argument was that because of the progression of disease of cervical cancer and HPV disease, that it's such a long progression and it takes time to develop that the potential benefits of continuously testing is not worth the cost and unnecessary invasive diagnostic testing like the colposcopy. So one of the things though that this paper brought up is that with this change, they've noticed a decrease in detection and treatment of chlamydia. And basically, the paper is published in the Annals of Family Medicine, and it's a study done by Namer et al. And the paper looks at the impact on chlamydia incidence in light of this change in screening guidelines. So basically, the study looked at data 2 years prior to and 2 years after the implementation of the change and found a reduction in chlamydia testing in females. And ironically enough, the incidence in the male population did not decrease during this time. So I thought it was kind of interesting to see that although, and again, the data is not there right now to show whether the change in this guidelines of from the ASCCP, what the impact has had on cervical dysplasia and the detection and the incidence of cervical cancer in general. But it goes to show that there are other areas that's been impacted by this guideline and changes.
Yeah, I think before we get into the cervical screening stuff and the unintended consequences, I just want to stop for a second and talk about the actual what they found here is that they showed a decreased incidence from 26 to 18 or something like that, right?
Yes.
And we'll assume that the actual incidence didn't change. It was just the number that were picked up. And we already talked about, and I would say a little bit too exhaustive discussion on PID we did in the fall of last year, that each one of those women that you don't pick up is a woman who could end up with PID, who could end up with infertility, who could pass it on to somebody else. And all the costs that are downstream of that can be huge.
Right.
So this is not something so we missed a few women with chlamydia. I just want to make the point for all the listeners that to me at least that is a huge deal.
Mm-hmm.
Right. But going back to the cervical screening and this, in fact, I found this fascinating. It really comes down to unintended consequences, but also public health versus personal health.
Right.
And with this discussion we have all the time, especially in pap smears and mammograms, is that public health applies to a large population of women, but each individual woman's health is her own, right? So, especially with pap smears, so agreed that, we think that by decreasing the interval between pap smears, that we're going to decrease all these unnecessary tests and leaps and maybe preterm labors and all that kind of stuff, incompetent cervix, which will be good. At the same time, there's a woman out there who you didn't pap this year who has cervical cancer.
Mm-hmm.
Right?
And I see some patients in the clinic who actually say that. They say, how come, 3 years ago this wasn't there? Maybe if I had gotten annually, you guys would have picked up this cervical dysplasia earlier. And to be honest, I don't have an argument. It's just that luckily so far, most of them have been like CIN1s or CIN2s, but who knows, maybe that 1 year difference made a huge difference in that person's life.
Right. Well, statistically it will. Like eventually you'll find that woman who would have benefited. But that's how population health works.
Right.
And the other thing that found me interesting, well, before I get there, you brought it up, but a lot of people, OBGYNs, were, I don't want to say upset, but they definitely were worried about this change from yearly to 3 years or whatever, because this exact reason that women wouldn't come for their annual exams.
Mm-hmm.
And at the time, I kind of poo-pooed that, to be honest with you. I mean, most of what we do as an annual exam is actually not helpful. If pap smears every year don't help, okay. We already know that clinical breast exams are essentially useless at picking up meaningful breast cancers. And we have no screening test for ovarian cancer, so what are we really doing, right? Well, I mean, we are doing things. We're talking to the patients, we're asking about menopausal stuff, new sexual partners, and I think this highlights why the annual, I don't even call it an exam, But the annual discussion with your patient is so important because it gives you the opportunity to talk about things like this.
I agree. And I think that's kind of another impact of having this decreased interval between pap smears is that I think sometimes the rapport with your patients could be affected as well. Because I think when they come in having some type of expectation and you say you're not going to do it, and that also kind of affects how they're going to view their annual exam the next year, as well as the fact that if they don't think it's necessary, they're going to just stop coming altogether to annuals.
Right. So to me, this is thinking, all right, I don't think we should change the way we do our cervical screening because that's evidence-based. And as people who listen to this podcast on a regular basis have figured out by now, I'm an evidence-based person. I try to live my life by that. Right. So I don't think we should change our cervical screening criteria just to affect something else. But it gives us the opportunity, or makes us have the opportunity to say, okay, so how can we do, for example, chlamydia screening better?
Right.
Right. How can we change the way we do it? Because before we were already in there doing this PAP, so we might as well do GC chlamydia testing, right?
Mm-hmm.
So is there a different way to go about screening that doesn't include a PAP smear that we can implement? So how do we get the best of both worlds?
Right. And I know there's some papers that show that, I think it's recently published, chlamydia testing, like that study looking at vaginal swab versus urine chlamydia testing, and they show that they're pretty sensitive in detecting chlamydia in patients.
Yeah, the one paper I found on that showed a sensitivity for the endocervical, which is what we traditionally do when we do a pap smear, of basically 92%, with the urine being similar at 92%. What was interesting to me, though, is the vaginal swab was actually 97.2%.
Yeah.
So the vaginal swab was better, and that was, by the way, done either by the physician or by the patient herself. Right?
Yeah, I think I'm not sure if it's the same paper. I think that was in the New England Journal of Medicine. That's the one I looked at that showed that vaginal swabs are better. And if the patient herself could do it, and if that's that sensitive, then that's another way for us to test for chlamydia, instead of subjecting patients to another speculum exam, which sometimes if you say, I'm only going to be doing speculum exam just to do a GC swab, some people do refuse that.
Yeah. I mean, I think, honestly, if we could eliminate the speculum exam from our routine practice, we would have a lot more women who wouldn't hate going to the gynecologist.
I agree. That's like the worst part of going to a gynecologist.
Right. And so, for some things you need it. You want to look, whatever. You need it sometimes. But for routine screening, if we could, with the HPV testing instead of pap smear testing, if we could get rid of it, that would be wonderful. But at least for GC chlamydia, it seems like we can get rid of it. But the question isn't to me so much how we test, but it's how do we prompt ourselves to ask the patient to test. Right. So when you lose that annual appointment with you to come in and talk about all these things, then you miss that opportunity to say, hey, do you want to get testing for gonorrhea and chlamydia? Because you're at risk. Right. So how do we recreate that connection with our patients when we eliminate the pap smear?
Right. I guess that goes back to us having this relationship and rapport with patients to kind of try to show that the annuals are needed. And I think that's something that we need to work on as OBGYNs to also say, okay, annuals are not just for pap smears, and even for STD testing, that we have to look at the woman as a whole and think about it when we think about it as a woman visit, that there are some things that we need to kind of address with them on a more personal level. And I agree that even if you have a very effective testing and a very sensitive test for chlamydia, if they're not coming in, then we're not going to detect it.
Right. What you just said, I was thinking this today, as a matter of fact. Annuals for gynecologists can easily devolve into breast exam, pap, gonorrhea, chlamydia, contraception. All right, thank you. That's it. Come back next year. Right. And when we start removing those items, the breast exam, the pap smear, what are we left with? Well, there's a whole host of things, and ACOG has this up in their bulletins, of things that we can do for these patients, because a lot of times we're the only doctor they see. We can do screening for domestic violence. We can do hypertension screening. We can do lipid screening. But all of that takes a lot longer than PAP and a pill.
Right.
Right. And so we have to, it's like reorganizing the entire way we approach our office session, because counseling takes way longer than just doing a PAP smear.
Right.
Right. But that we have to give the patient some value to that yearly exam. And if we're not doing these other, basically easy procedures, we have to do the harder stuff. And I think for me personally, that's a challenge, to orient myself towards the annual exam in order to give that patient some value.
Right. And part of that is just the nature of what we do. We see a lot of patients in clinic. Sometimes you can't really devote all that time. And some patients also have a PCP, but not everyone does. They do look at their OBGYNs as their primary care physician. And I think it is our responsibility in some ways to kind of, treat, at least screen for things and ask the patients questions to that kind of looks at the woman as a whole. But I'm not going to lie, that's something that I don't always do when I see a patient for their annuals. And sometimes patients come in to their OBGYNs with the thought of, I'm only here to just get a refill on my OCPs. And so even if I try to go into a discussion about, how are you doing in school, or how are you doing in life? Everything going okay with at home? Do you feel safe? It's just kind of shrugged off as, can I just get a refill on my OCPs? And I feel like maybe in the public eye, that's kind of what, they view OBGYNs as, people who are going to be there for STD testing, PAP tests, and breast exam, and just contraception.
Yeah, well, you're actually getting to the heart of an argument that happened well before you were an OBGYN, and to a degree myself, when the ACOG decided that we were going to be primary care providers. And that had to do, I think, mostly with reimbursement and things like that in the U.S., but there's this big push for us to be primary care providers, and now it's kind of come back the other way. But that's right at the heart of that. Like some women don't come to us for that, right?
Right.
They just want what they want, and they want to go to get out. And it's amazing how I have some women who I feel like I do absolutely nothing for them when they come for their annual, and they're like, it's like they checked off a box that they did that for the year, and they're happy. That's all they want. They don't want to talk to me. They just want to get their PAP and their breast exam and their mammo prescription, and then they're like, yep, check, I did that for the year, and I can move on.
Right.
And other women, they want more than that.
Right.
Which is challenging. And we've definitely completely gone away from what we started on this conversation about chlamydia screening.
Right.
But I think it all does kind of come together. We have this population health point of view. We have this relationship with our patients, and how do we get them to come back? And then also, how do we incentivize women to get chlamydia screening? And those are all hard questions, which neither you or I are going to answer on this podcast. But I'm happy that someone wrote this paper so that we could bring it up to our audience.
Right. And I think that's a good way to sum up the paper, that although they found this, of the fact that we have now decreased incidence of chlamydia because maybe we're not screening them with pap smears. Is that the only reason? Is it because maybe women are not coming for the STD testing in general because they're not coming to their annuals because they're not due to their pap smears? So I think it's a paper that has multiple layers and kind of highlights some other issues, not just about the effect of pap tests on chlamydia screening.
Yep. And I think that we have beat that one to death. Now, for all your listeners, all of these papers and everything are going to be in the show notes, so you can read them yourselves. Also, some of these other papers that we mentioned or quoted here, we'll put those in the show notes if we can as well, so you can all read through them. So that gives us time to get into one last article, and this one is actually not a scientific paper, which I kind of liked. This is from a website called Timeline, although I think it was other places as well, and it was titled, "The Inventors of the Pill Decided Women Should Still Bleed Every Month." Now, we talked about contraception, again, ad nauseum not that long ago, and I spent an entire episode on the pill. And what I really found interesting about this is part of it is how do you allow women to accept a new medication and a new way of thinking about their fertility? And then the second thing is, what do you do when that mentality is no longer needed? Right? So essentially what this paper was saying, and absolutely correctly, is that the pill was designed with this monthly bleeding for no purpose other than to allow women to have a period because they were comfortable having a period every month knowing that they weren't pregnant. Right? There's no physiologic reason if you're on the pill to have a menstruation because there's no real lining to come out. Right? And that's done on purpose. Right? It's the way the whole pill works, and we've already discussed that. And again, back in the 1950s and 1960s, when the pill was a new thing, women had to be convinced that this was safe, right? And they had to be convinced that it was natural or normal. And so having that withdrawal bleed every month, mimicking their non-pregnant state, was comforting to them, right? And allowed more women to accept it culturally, or at least that's what the men who designed it thought. Right, women might have actually been just fine not having periods, right?
Right.
But and that's a whole different discussion about men's place in medical history. But in any case, that's what the men thought, and we have no real contemporaneous, female commentary on that. So for the moment, we'll assume that was true. But in any case, now we're here at 2017, right? So 1957 is when it came out. So we're a good long ways after the pill was manufactured, and yet we're still making pills that most women have a period every month. And do we need that anymore?
Right. And I wonder if it's actually, when I read that article, I found it very, very interesting. Part of it was, I'm a woman, so, I, personally, have menstrual cycles as well. And it's just interesting to kind of look at that the pill was designed to mimic normalcy and naturalness, but it's not natural. And they thought that having that would make the women more amenable and agreeable to taking the pill. But what's surprising is that although that was back in the day when it was made created by John Rock, that a lot of women even now sometimes ask me, if I take it continuously, is that safe for me? Like, is that normal? Am I okay? I'm not supposed to have some bleeding either way. And that goes to show that though that idea of having a menstrual cycle and, saying that the pill is normal has percolated even now and trickled down to how women view menstrual cycles today. Granted, not everyone thinks that, but that's kind of, it's an effect. And that big decision that was made when the pill was initially made, I think that idea that idea has kind of permeated even our culture today.
Yeah, I would agree. In my practice, I have a very few, percentage of women who want the extended cycle or amenorrhea. With the IUD, it seems to be okay. Women are okay with that concept. But when taking pills, they really want that monthly bleed. And I don't know how much of that is... Actually, I'm pretty sure most of that is the reassurance every month that you're not pregnant.
Right.
Right. So there's something to be said for that culturally. Now, is that because that's the way it's been for the last 60 years or 70 years? Or is that something inherent in the, oh God, I'm going to kill myself for saying this later, but the female psyche, right? Which is ridiculous. Please don't write me and tell me that was ridiculous. I know.
Yeah, you might regret saying that later.
I'm going to regret saying that. Because I don't think that's true. I think it is more of a cultural, this is normal, and even on the pill, this is normal. This is what your mother and your grandmother, this is what they had, and so this is what you have. But there's certainly, I hear a lot of women say exactly that. Well, how do I know I'm not pregnant if I don't have my period?
Right. Even though that's not your period.
Correct. Right. And, there are seasonal and seasonique, and there are these brand name, or some of them are generic now, but most of them still brand name methods for extended cycles. And they do decent business, but nowhere near what the regular monthly pill does.
Right.
Now, one of the things I wanted to just bring up on this is, okay, just because we think there's no reason to have it, is there a downside to not having your period? Right? So is there any evidence that if you don't have a period for 9 months or a year when you're taking the pill continuously, are you at risk for endometrial hyperplasia? Right? Are there other risks there? So I looked it up a little bit. There isn't a whole lot there, but it seems to be the answer is no.
Yeah, I mean, so if there's no risk, and I wonder if that's something that we also need to tell patients, is that when we're giving the pill and they're adamant, and it's a personal choice. I think at the end of the day, it's their choice. They really want to not be on the extended or be on the continuous. They could definitely have this withdrawal bleed, as we call it. We need to, I think it's a matter of a discussion with patients to tell them that there really is no risk about it. But I wonder if that's going to change how people view the pill, even if they know that there's no risk about it.
And what do you mean by that?
So even if, let's say, we tell patients that there's really no risks of you taking it continuously and, not bleeding for 9 months, would that still convince patients to opt not to have that placebo week?
Well, I don't know. This is one of the things that I talk about a lot with residents and even patients sometimes, is most women, well, it changes a little bit in the last few years, but most women come to us because we're the experts, right? So if you go to an accountant or a lawyer and you say, this is my situation, give me your advice, like, you want their advice because they're experts. Right. So you are already primed to do what they tell you to do because you went to them to begin with.
That's true.
Right. And I think that for us providers, we don't recognize how much that's true for us sometimes. Women come to us wanting a recommendation. Now, some people, and this is not just women, it could be in any field of medicine, go to the doctor already knowing what they want. Right. I have an ear infection, I want amoxicillin. Okay. So I could spend the next 25 minutes talking to you, trying to convince you don't need amoxicillin. By the end of the day, if you don't walk out with amoxicillin, you're going to be upset.
Right.
But for birth control, at least, I think most women come wanting our opinion and our recommendation.
That's true.
And so I think if we spend the time to explain the rationale and the reasoning behind continuous or extended birth control, I think that a lot of women would go for that. But that takes time.
Right.
So how much time do we want to spend when you have 4 patients waiting to see you? And I hate to bring things into that level of money and time, but a lot of it, that's what we do on a daily basis, is how much time do I have to spend with each one of these women to explain something like this?
Right. And it kind of goes, it has nothing to do with the paper, but I wonder how much of it is cultural in a way too, because I know some countries sell birth control pills over the counter and they don't require any counseling in the office. They go out to a regular CVS like place in the country and able to buy OCPs over the counter, and there are directions in the back of the insert and they just kind of take it as is. Some of them take it continuously and they're happy about not bleeding, but they don't. It's not a discussion in the office with the gynecologist as to how do they take it and what's an option for, what are the different options that are available. So I wonder if there's some component of how, depending on the role, I guess, that OBGYNs have in different cultures and maybe different countries, what the expectations are of the patients to go into when they see their OBGYNs, like what the kind of discussions they're expecting to have in the office.
Yeah, I mean, well, that's a rabbit hole that we can dive down a little bit, but not too long because we're running out of time here. But first of all, you have to remember that the OBGYNs like we have in the U.S. are kind of a U.S. construct. Most of the world does not work like we work, right? Where in most of the world, European and other places, the OBGYN is more of a specialist as opposed to your general practitioner, right? And so that is a difference. To go on your thing about buying pills over the counter, again, those who listen to the contraception episodes know that I am a strong proponent of easy access to contraception.
Mm-hmm.
And I think that I would pretty much be okay with women being able to buy contraception over the counter. However, I think it goes back to our last conversation is what are the unintended consequences of that?
That's true.
Right? Do we now, if they don't even need to come to us for birth control, we're never going to screen them for chlamydia, right?
That's right.
All right, amongst other things, right?
Right.
So I think there's some unintended things there that we don't want to overlook. But again, I firmly believe that cheap and easy access to contraception makes the
Mm-hmm.
entire society better. And surprisingly, there actually aren't that many countries that allow you to buy it over the counter. There are a lot that make it easier than we do here in the U.S.,
Mm-hmm.
but very few countries actually allow you to buy it over the counter,
Okay.
probably for similar reasons.
Right.
Although in California, they do now, there's an app that you can go on, log in, give your medical information, it goes to a doctor, and then that doctor prescribes the birth control for you, so you never have to go to the office.
Oh.
Right, and that it costs money. I forget how much it costs, but
Yeah.
it's not too much.
Right.
But you never have to go to the office. You can just go on the app and do it.
Mm-hmm.
It only works in a few states right now. But I think that's an interesting approach as well.
An interesting approach, but kind of going back to what you say, I wonder how that's going to change with our role in patients and their visits, because it might be interesting to just see how, and I agree, in countries that have OCPs over the counter, what their, I guess, OBGYN visit rates, I guess, are, and how those people and those patients view OBGYNs. Maybe they don't even have a gynecologist. Maybe they've never even gone to see one, and they're just buying OCPs over the counter. So it is one of those things where it probably has other consequences down the road that that we don't necessarily see here because we don't necessarily sell it over the counter.
Yeah, I definitely that's a good idea to look at other places who do something different than us and see what the rates are. But again, you're comparing two different cultures that go along with that, so it's hard to draw too many conclusions.
Mm-hmm.
But at least we can get some idea. Well, anyway, I think that we definitely raised some interesting thoughts with all three of these papers. These are all, as you would say, ripped from the headlines. So I hope that you all enjoyed listening to them, and maybe you had already come across them in your own reading. But if not, well, here you go, some good reading material for the weekend. Thank you, Dr. Kim, for sitting in with me and going through these papers. I really appreciate your time.
Thank you for having me.
And we should be back in the next week or so with a Journal Club episode. I know that was a little delayed from this earlier month, but as it turned out, we took a little unanticipated summer holiday here due to some vacations amongst the three of us. But anyway, we should be back with that. And then Dr. Kim has an episode coming up in the near future on cholestasis, and then I'll be back hopefully soon with a new series on polycystic ovarian syndrome, which I think should be interesting. So in any case, thank you all for listening. I hope you really enjoyed it. As always, please remember we have the Slack open for anybody who wants to join. Just send me an email at feedback.obgyn.fm, and Dr. Kim will be there to greet you as well when you come in the door to the Slack. Mm-hmm. You can send any other feedback back also to that same email. And please, if you have a moment, consider dropping a review in iTunes. I'd very much appreciate it, and it does help other people find the podcast. And with that, I say thank you very much, and until next time.